Indeed, I'm going to talk about commissioning, which seems to me to be one of the things that really was at the root of what went wrong around the Winterbourne View scandal and abuse. But of course, I can't resist the opportunity to, before that, make a few wider comments as well. So I will do so. I won't say much about the NDTI. I guess most people know bits about it. There's some stuff in your booklets about us as an organisation. Just want to emphasise, although many people will know about us from our roots in the National Development Team, just to say that nowadays we work around and are interested in a wide range of excluded people, older people, people who have mental health problems, younger disabled people and so on as well. And our work is around trying to ensure people have more inclusive lives in their communities. 3 key questions about Winterbourne View. Now, I suppose I need to kind of put, before asking those 3 questions, put my cards on the table as to where I stand on this. And my views and positions, I think, are broadly similar to many others. For example, those 86 people and organisations who signed a letter to the Prime Minister that I assume most of you have seen, in that we very clearly strongly believe that there is no place for learning disability hospital provision where people live and are for a period of time beyond the need for a very small number of assessment and treatment beds that are linked to and integral to local community supports that are aimed at supporting people to live in their local areas. So the starting basis behind asking this question is, why does a learning disability hospital that draws people from a wide geographical area and then takes them in for a significant period of time exist? Because evidence says clearly that if we do things right, services and facilities like that are not needed. To briefly support that case, let me quote Eric Emerson, who would have been here speaking had he not somehow managed to wangle a job that involved people paying him to go and do work in the Cook Islands today. Outrageous. I want to know how he does it. Eric was speaking at Jim Mansell's retirement do at the University of Kent a few weeks ago. And he made a number of key points from the learning that he and others had done in supporting the people with the most complex behaviour, who were labelled as challenging from the old Southeastern Regional Health Authority, Learning Disability long-stay hospitals. He'd led the team to plan those people to get individualised, community-based supports. So from looking across that whole hospital, he had some very clear conclusions based on experience and evidence. The first one was that nobody whose behaviour challenged needed to live in an institutional setting, without exception. Secondly, that no one needed to live with or benefited from living with other people who were also labelled as challenging, which is what that type of provision does. The third thing is that behaviour that challenges is best understood as being functional. In other words, what people are doing is trying to communicate and express something. The behaviour is trying to serve a purpose, because most likely they are not being heard and listened to. And that doesn't explain everyone, but the clear evidence is that if we start with that as a starting assumption, that the person's trying to communicate something, then that is the best way to start understanding how to support them. And fourthly, the fact that almost all behaviour that challenges starts in childhood, and therefore we need to think about early interventions. You put those things together, and it's clear that services of the type of Winterbourne View are neither necessary nor desirable. So it seems to me that the 3 key questions are, why are people placed there in the first place? And that's what I'm primarily going to focus on. Secondly, why, once there, did nobody pick up on what was going wrong? That brings in questions, certainly for the commissioners, but also for the regulators as well. And thirdly, why did the provider allow such poor quality provision to be provided in the first place? So there are different areas of responsibility between different people and organisations, and I'm going to focus mainly on the first one with a little bit of the second one, i.e. the role of commissioning in this particular situation. Now, I'm going to pose the question of why were people there, and I think there's this simple logical route through. Now, I'm not going to stand here and say that is why everyone was there at Winterbourne View. There's a DH inquiry and review that will come up with detailed information around those. But both from my experience over the years and recent NDTI work in other areas, it's very clear that this is the story of what happens most people are in those services because they have been failed by other services. Other services have not met their needs. And generally, that starts with what we might term social care commissioning. You know, there's been a bit of an argument with some people in local authorities saying this is NHS responsibility, they commissioned it, it's a health service and so on. But the reality is that what happens is that people usually start off with having services commissioned to support them that fall under this general banner of social care, housing and support in their local communities. And more often than not for the people who are involved, those services did not meet their needs because they were not commissioned in line with the best evidence and knowledge and good practice around people who are labelled as challenging. As a consequence of that, people's behaviour, because they weren't being listened to and so on, my earlier point, became what we label as being challenging, and that resulted in increased input from health professionals, and over a period of time, the commissioners in that continuing care interface that someone asked a question about, and I'll comment briefly on later on, began to argue that this was increasingly an NHS responsibility, became deemed to be continuing care or largely continuing care, 100% NHS funded, NHS purchase placements, and NHS commissioning has very little capacity and expertise around learning disabilities, and therefore doesn't understand things like the Mansell report and the evidence, and ended up going for the easy solution, which is to buy a place in a learning disability hospital. Anecdote time, 4 days after the Panorama programme was on, I met for the first time in a theatre, bizarrely, somebody who was one of the commissioners from a PCT that had bought places in Winterbourne View. So they started saying, wasn't it dreadful, Castlebeck, how dare they behave like that? And I said, don't you think you've got any responsibility around this? You placed the person there, to which this person said, but what was I supposed to do? I had the consultant psychiatrist telling me it was in their best interest to go there. Which begs for me two questions. Firstly, why did a commissioner not know the knowledge and the evidence base to challenge the psychiatrist? And secondly, why was the local clinical lead recommending that as a solution? Because they should have known the evidence and best practice basis. So, to me, our evidence and experience, and we're working in an unnamed area at the moment that reconfirms this, that's the pattern and story that we have to break into. And that's why commissioning is so important. And commissioning, I think, has to start from the point that both Roger and Viv were talking about earlier, which is what's the value base that you start from? Do you genuinely believe and understand that people with learning disabilities who are labelled as challenging have exactly the same rights and should have the same opportunities as everyone else? Or do you believe that, well, they're special? You know, they're special, so we've got to do something special and something separate because they can't actually achieve the same things as others. And sadly, in my experience, we find that many people who are involved in services for people labelled as challenging believe the latter. Now, if you believe the latter, it seems to me you begin to ask questions about service, which is clinical service delivery. You know, are we ticking the boxes in terms of clinical outcomes? Continually the question will be what's going wrong? The focus on surviving today, on asking professionals what they think, and in financial terms asking how we maintain the same for less money. If you take the view that what you're about is supporting people to live equal lives in the communities, then you ask a different set of questions. You ask about quality of life outcomes. You ask the person themselves and work with their family to find those answers about whether services are working or not. And that, for me, is an underpinning question that commissioners have to be asking. Where are they coming from? Do they genuinely believe that people can and should have the same rights as others? So, in response to that conundrum, the NDTI was commissioned through the Department of Health about 2 years ago to develop guidance on commissioning services for people who challenge. And the reason that this happened was that the Mansell report, which is absolutely spot on and excellent, doesn't really give the answers to commissioners on what they should do. It says what should be there, but kind of how do you get there? What do you need to do differently? So this guidance that we developed, and the web reference is at the end for that, was about trying to inform that. So we basically went out and tried to find places that had made progress in developing services that fitted in with the approach in the Mansell report around individual community-based services. And this next to last point is particularly important. We only took as evidence places that could evidence both improved outcomes for people and the costs, the financial costs around doing that, which meant We weren't looking at a large number of places, it has to be said. But that for us was important because we wanted this to be an evidence-based piece of work. What this did was identify 7 key areas to consider, and while I slurp my tea, you can have a quick read of those 7. Because I'm now going to go through them one by one and try and explain in quick outline terms to you what the things were that we found and therefore what needs to happen locally. Now, I'm conscious there are actually very few commissioners in this room looking at the list. So from your perspective, think about the whole service system if you're not a commissioner and how you can play a part in creating a whole service system that does those things. The first area, not unsurprisingly, is about clear vision and values and a commitment to those principles of ordinary life. I won't reiterate it, the sort of stuff that Roger and Viv have both been talking about. But crucially, that there is an understanding of the evidence base from key players. So you don't have commissioners who say, I just had to do what the psychiatrist told me to do, which in that case was not a good thing to be doing. Sometimes it is, sometimes it isn't. But actually people understood the evidence base based around some kind of agreed strategy. And I think 2 key points around this are really the 2 key bottom points, because those top bits are arguably just logical, aren't they? Even allowing for the fact you will rarely find it, I would suggest. The first is an understanding this is not a quick fix. You will have to be working, as Viv was talking about, for a long period of time to support people to make progress in their lives. So it's not something that you can do it, problem sorted, save a few £100,000. An understanding that this is in for the long haul. And therefore, that everybody buys into the fact that they've got to, we use the phrase, keep the faith, because things will go wrong. So have you got buy-in to the extent that people are accepting that when things go wrong, i.e. your service might break down in some way, that doesn't mean you immediately say, it's gone wrong, let's go back to the institution. You actually sit back and work out what went wrong, why, and replan and do things differently. So the first area was clear vision and values, and the key bit there is about buy-in and understanding from key people. Now, central to that was the element about leadership. With commissioners being actively involved in service development, they have to be actively involved, but it's also worth saying that in some of the places, what the commissioners had done was effectively delegate that to somebody else, like a key player in the NHS Trust, to provide that leadership, but with their authority and their endorsement. And that leadership in the commissioners, in the providers and other places, were clearly legitimised and supported to take sensible risks. This is not a small c conservative approach. One has to take things that would be perceived as being risks. So have you got a culture that actually will allow and enable that to be the way in which things are developed? And a particular element of leadership that we want to emphasise, because it came through so strong, and I'll touch on this again in a minute, is the point about having clinical leadership that believes in the outcomes around the Mansell report. There's stuff about this tension between the social model of disability and the medical model that I again will touch on in a minute. But we want to emphasise that clinical leadership is absolutely essential and has to be there, but it has to be clinical leadership that believes in the Mansell report. Relationships is possibly the most important bit, and this first point, the places that were making progress had developed a no-blame culture. So when something went wrong, as I mentioned earlier, as things often will, the services will fail, and emphasise it's a service that fails, not the person that fails, then rather than say it's your fault, we're going to whip the contract away from you or whatever, a culture and approach which is focused upon saying, let's work out what went wrong and we will redesign this together. People and families clearly at the centre of decision making. The stuff that Viv was talking about earlier is essential components of that. With the local authority and NHS in it together, sharing resources, sharing financial risk. I'll touch on that in a minute. We want to emphasise that one bit of relationships that was important that we found where there was progress was about the commissioner-provider relationships. Traditional tendering processes were not being used and did not work, right? Because that created a relationship that was about conflict and tension. Rather, the places that were making progress found people who were interested and wanted to work with people who were labelled as challenging and entered into ways of having long-term relationships with them. It's too complex for me to explain in my limited time, but if you look at the publication, you'll see more detail about that. So getting beyond simplistic tendering, which is sadly becoming the norm, it seems. And importantly, clinicians and providers using each other's expertise. Let me kind of slightly parody this. I'm back to this social medical model tension, because often with people who challenge, what you have got is a standoff, between medics who say, these social care providers, they're so right on, they're falling off the end of Brighton Pier, they don't recognise the reality of what's going on, while you've got people who are working in supported housing saying, these bloody medics and the like, all they want to do is prescribe people with as many drugs as possible, right? Parody. The reality is that the places that made progress had an understanding of the contribution that each made. And if the clinicians were saying, for good sound reasons, this particular intervention has to be done in this way with this type of staff practice, then it's done. No questions asked. But equally, if the social care providers are saying, there's a problem in doing things in this kind of a way, we have to, because it will undermine the capacity for somebody to become an effective member of the local community, then the clinicians understand that and shift and change their advice accordingly. Mutual respect as opposed to standoff, which is what I think we've seen in many places. I'm running short of time, so I'm going to have to zip through these next few. The service model is really important. Clearly, use of person-centred approaches. Services being co-designed for everybody else, by everyone. So it wasn't a case of, care managers and commissioners specify a service and then go out to tender. No, the care managers, with health professionals, with the family, identify a provider right at the start, and together people work to design a service that is going to work, because that has greater buy-in and is more likely to work. I've talked about clinical leadership, clearly the use of non-aversive techniques. What I haven't put on this slide, but as it was mentioned earlier by Roger, I think I'll mention it, around avoiding the use of antipsychotic medication. If I can quote Eric again, I'll obviously have to start buying him a beer for quoting him so often on this. I remember there's a quote he's made that I remember, which is that if somebody whose behaviour is challenging does not have a diagnosed psychotic illness, then antipsychotic medication has absolutely no effect on the behaviour whatsoever, unless and until you've given them so much medication you're effectively stopping all behaviour. Right? And yet there is widespread use of antipsychotic medication to control behaviour that challenges inappropriately. Worth emphasising here the separation of housing and support. Not everywhere, but a lot of the best places have clearly got a model where, back to the rights agenda, people had housing rights, and housing and support were separated out in ways that worked. And service costs I'll come back to in 2 ticks. Skilled providers and staff. I think I'll just summarise this one quite simply by saying the key starting point was actually about finding providers who wanted to work with people who were labelled as being challenging. I think it's back to some of the stuff Roger was saying with some of his graphs and diagrams. Frontline staff have to want to have a positive relationship with the person, as opposed to viewing them negatively as someone they've got to control and they've got to survive the day on shift, which is sadly what happens in many services. So therefore the recruitment of providers is done on that basis, not on the basis that they've got a nice glossy brochure and the right qualifications, but are they actually committed to equal lives in the community? Are they using staff recruitment practices based on that? Are senior managers directly and closely involved using clinical expertise? And interestingly, this point, nowhere where we found good progress did people use agency staff, because of the inconsistency that brought to the interaction with the person who was labelled as challenging. This is the other one of the I said relationships is important. This is the other one that's really important, I think. Where there was progress, commissioners actually could evidence it. There was an outcomes framework, and we don't just mean important, though, the sort of stuff Roger put in about levels of intervention and behaviour that challenges and so on. This doesn't just mean clinical outcomes, it means life outcomes for the person. Most services, most commissioners are unable to provide that. And indeed, if you can't then also evidence the cost impact over time of changing services, my question is, how can you commission without those 2 things? It is to me a contradiction in terms if you don't have an evidence base and costings information. But those 2 things will enable you to ensure you're using money wisely. So I come into my final section. The final section was really, we identified 6 things, and then there was lots of other little things as well, so we had other commissioning actions heading to fit everything into. They're fairly self-explanatory, so I won't talk about most of them, other than the bottom 2. Creative use and continuing care criteria. There was a question earlier. situations where the local authority and NHS operate on the basis of they're very challenging, therefore it's clearly 100% continuing care funding, do not help and support the delivery of this agenda and the delivery of what the Manser report says we should be doing. Rather, it's important to understand that there are elements of ordinary life in the community for everybody that should be funded by the local authority, and there are ongoing specialist health expertise needs that should be funded in order to support that way of delivering services. So most of the most effective services were delivered by joint packages of funding of care, and then that avoids the question we heard earlier about the continual drive to remove NHS funding, and it's understood to be a long-term partnership funding with shared risk and shared financial benefits. Because one of the things I didn't say is that one of the places we identified for an annual investment of £400,000 was every year saving £900,000 on what it had cost them with out-of-area placements. And that financial benefit went back equally to the two authorities as part of the sharing. And this last point was really crucial. It was really crucial because of the current financial climate. An understanding that because you have high costs to start with, everybody, including the provider, knew and understood that the agenda was to reduce costs over time. Everybody bought into that. But it only happened when the outcomes evidence showed that a person's life and outcome were improving, and that a reduction in the cost of the service made sense because it was about helping them move on to the next stage of their life. Which is why that outcomes and cost information is so important, because you can't do it without that. That's about it, because I'm running out of time. It's out there, it's on the website. We've also got a quick audit process we can use. I just want to confirm that what this work did was confirm that you can get good outcomes for people. That web page up there is where you will find the full documents if you haven't seen them. And also because I'm conscious, because of a combination of holiday and our failed IT system, you haven't got my presentation. I'll make sure the presentation's up there in a couple of days' time as well if you want it. Thank you.
Thank you, Rob.